Hi guys, welcome back to another episode on the Read Harrison series. So in one of the previous episodes, we have discussed about hemochromatosis, and the exam going students were also requesting me to cover the Wilson disease. I will keep it simple, focused on the exam going students, but at the same time, we will touch the key points that are required for your NEET PG preparation. So what is Wilson disease? Just like your hemochromatosis, where there was systemic iron overload, Wilson disease is a condition where there is systemic copper overload, right? So let us learn about Wilson disease today. The Wilson disease is also known as hepatolenticular degeneration. I want you to remember this name because examiners need not always mention it as Wilson disease. Hepatolenticular degeneration. Why is it called as hepatolenticular degeneration? Because the two most commonly affected organs by the copper overload, one of them is liver, the second one is lenticular nucleus, which is part of the basal ganglia, right? Neurological manifestations. That's why it is called as hepatolenticular degeneration, or you can also call it as Wilson disease. It is an inherited disorder of copper metabolism where we have systemic copper overload. Systemic copper overload. And what is the reason for this systemic copper overload? Of course, I have already told you that this is an inherited disorder. That means there must be some mutation, and I think all of us know the mutation. Mutation in ATP7B gene. Now, this ATP7B gene codes for a copper transporting ATPase enzyme. So, very, very important. We will understand its pathophysiology later. Now, this gene is present on chromosome 13. It is present on chromosome 13. One of the MCQ the examiners may be asking you is, what is its mode of inheritance? This mutation is inherited as an autosomal recessive condition. It is inherited as autosomal recessive condition. Now, before we understand the disease proper, let us take a quick look at the copper metabolism that we need to know to make the disease clear. Now, when we take copper in the dietary form, especially seafood and vegetables are good sources of copper. So, when we take copper in our diet, this copper will be absorbed in the intestine through the intestinal cells called as enterocytes. So, let us say this is one enterocyte I am looking at, and the copper is passing through it. Now, I have to get this copper inside this intestinal cell and then shuffle it out into the portal vein so that it goes to the liver. So, to absorb this copper into the intestinal cells, we have a transport molecule which is called as copper transporter 1 or CTR1. So, CTR1 will shuffle the copper molecules from the intestine into the enterocytes or intestinal cells, and from the enterocytes I have to shuffle it out into the portal veins. So, for that I have one more specialized copper transporter, and this copper transporter we will call it as ATP7A. I think all of us are familiar with this ATP7A mutation. What disease does that cause? 7B mutation causes Wilson's. If this ATP7A is mutated, yes, we get into what is called as Menkes disease, right? Menkes disease. So this, if it is mutated, then we will not be able to get this copper into the circulation. From the intestine, we will not be able to absorb the copper. So here in Wilson disease, that's not a problem. So I got my dietary copper. From there, the copper got shuffled into the portal vein. I absorbed the copper in the intestine with the help of copper transporter 1. And then from the intestinal cells, the copper was pushed into the portal vein through ATP7A. Now this copper comes to the liver. Now what liver does with this copper? Copper is an important component of an enzyme called as copper zinc superoxide dismutase 1, which is playing an important role in handling the oxidative stress. Apart from that, copper is component of various other enzymes. So it is essential component. So once copper comes to the liver, right? Let us see what happens to this copper in the liver. To zoom in, let us say this is one hepatocyte, right? Let us say this is a cell in the liver, hepatocyte. Now this has received the copper. Now this copper has to be stored and also distributed to different organs for the need. So I need a transport form, and you know that the transport form of copper, like we had ferroportin for the iron, we have a transport form which is called as ceruloplasmin. This ceruloplasmin exists in the form of apoceruloplasmin, which is not bound by copper. Now, once the copper comes into it, it will get bound by the copper and forms what we call as holoceruloplasmin. Holoceruloplasmin. And this is the ceruloplasmin that we refer when we say the serum ceruloplasmin level, ceruloplasmin level. We will call it as holoceruloplasmin. And this binding of copper to the apoceruloplasmin is catalyzed by this enzyme ATP. The gene for this enzyme is ATP7B. The name of the enzyme is copper transporting ATPase. Copper transporting ATPase. This gene is coding for this enzyme called as copper transporting ATPase. So tell me first thing, if I have mutation in this ATP7B, I can't make this copper transporting ATPase. And if I can't make this copper transporting ATPase, will I be able to convert apoceruloplasmin to holoceruloplasmin? No, right? Because I can't pack this copper into the ceruloplasmin. In that case, what will happen to this apoceruloplasmin? Basically, body has a mechanism. Any apoceruloplasmin molecule which doesn't get bound by copper will be broken down. And if I start breaking down these apoceruloplasmin, what will happen to the serum ceruloplasmin levels? So first thing that we can expect is the ceruloplasmin starts going down. Why is it going down? Because ceruloplasmin not bound by copper gets degraded in the body. So I start losing my ceruloplasmin value in the blood. Okay. Now this copper is not bound by the ceruloplasmin. This is free form now, right? So what will I do with this free form of copper? Whatever excess copper is toxic to liver cells as well as other cells. So this copper has to be excreted out. How do I excrete? It is excreted in the bile. So I have to secrete it into the bile. So this hepatocyte have to push this copper out. So this copper should be secreted out into the bile. And for this secretion again, the excretion of this copper is again mediated by same copper transporting ATPase, or you can say ATP7B. So if it is mutated, what will happen? The free copper will not be excreted in the bile. So this ATP7B is required for two functions. One, pack copper into the apoceruloplasmin to convert it into holoceruloplasmin, that is affected. And once copper is not bound to apoceruloplasmin, body starts decreasing it. So that's why ceruloplasmin level goes down. Number two, all that free form of copper that is excess should be excreted in bile. For excretion also, again, I need ATP7B. If this is mutated, I will not be able to excrete. So then what will happen to this copper? This copper will start leaking from the hepatocytes. It will accumulate in the hepatocytes, cause damage to liver, plus it will leak into the systemic circulation. And this free form of copper, because this free copper is leaking into the systemic circulation, what will happen to the serum free copper levels? Yes, they are going to increase. So now I will have increase in the serum free copper levels. But you should also note that we will have decrease in the serum total copper levels. You may ask me why? Because majority of the copper actually circulates in the form of holoceruloplasmin, means bound form. If ceruloplasmin is less, the total bound form will be less, but the free form will now be increased, right? Bound form is decreased, but free form is increased. Now this free copper goes to all the organs. One of the organ that it is going to reach is the brain. In the brain, it gets deposited in the basal ganglia and starts causing the damage to the basal ganglia cells. It is also getting accumulated in the liver, start causing damage to the liver. Apart from that, it goes to the eyes, gets deposited in the cornea as well as the lens, causes the damage, goes to the kidney, accumulates in the kidney, causes the damage. So let us see what all manifestations we can expect once I have this ATP7B mutation. We are going to call this disease as the Wilson disease. When it comes to the Wilson disease, if they ask you a question, what is the first affected organ? We know that the major load of excess copper is borne by the liver first. Then it leaks into the blood and goes to the other organs. So what is the first affected organ? Yes, it is going to be liver. Liver is the first affected organ. Now what all it can cause to liver? First thing it can cause to liver is it will start causing, as the copper accumulates, it is toxic, starts causing the hepatocyte injury. We will call it as as there is injury, we will call it as hepatitis. So it starts with hepatitis and then it will progress because chronic inflammation, as long as copper load is there, it keeps getting inflamed. It will lead to what we call as cirrhosis of liver. So one of the manifestations of Wilson disease is going to be developing cirrhosis of liver. Second, can it cause acute liver failure? Because basically the disease is a chronic disease, right? So we are expecting chronic hepatitis eventually leading to cirrhosis of liver. But can it cause acute liver failure? Yes, in some individuals it can cause acute liver failure. Acute liver failure. Now this acute liver failure, once upon a time we used to call it as fulminant liver failure. Currently we call it as acute liver failure. Now the presentation with acute liver failure is typically more common in children. The adults are less likely to present with acute liver failure. This is more common in children. In fact, majority of the children, if they are presenting with Wilson disease, they present with the liver involvement. Majority of the adults, if they are presenting with Wilson disease, they present with the neurological manifestations. Children mainly with liver, adults mainly with neurological manifestations. 20% of the cases get diagnosed when they don't have symptoms, but on routine investigation, we found out that serum free copper was high or ceruloplasmin was low. So that's how we get to know. But otherwise, 40% they present with liver manifestations, 40% with neurological. So in the recent times, one of the MCQ asked this: how do you suspect that a patient of Wilson has developed acute liver failure? So these are the clues for acute liver failure in Wilson disease. Instead of using the term acute liver failure, they may use fulminant liver failure or fulminant hepatitis. What are those clues? When we look at AST by ALT ratio more than 2, if they have very low ALP, or if ALP by total bilirubin ratio is less than 4. And because we're talking about it, there's another important point. Can you name any other condition where you have AST by ALT level more than 2? AST by ALT level more than 2, other than Wilson. Wilson is one important. Wilson acute liver failure often presents with AST by ALT level more than 2. Another condition which is more common, I see them every 3-4 weeks, at least one patient where AST by ALT ratio is more than 2. Okay, so remember, we get this AST by ALT level ratio more than 2, sometimes even 3 or higher in patients with alcoholic hepatitis. Alcoholic hepatitis. So until and unless I am suspecting Wilson disease, if I get the AST by ALT ratio greater than 2, first thing that comes to my mind is alcoholic hepatitis, right? So remember, now these are the hepatic manifestations. It can cause chronic hepatitis and cirrhosis, and in some people it can present with acute liver failure. These are the potential clue for a patient of Wilson disease going into acute liver failure. Now coming to the neurological manifestations. Neurological manifestation, the first site in the brain where the copper gets deposited. The first site affected in the brain is going to be basal ganglia. It's going to be basal ganglia. After that, the cerebellum and other structures get affected. And because of the basal ganglia involvement, you know that basal ganglia contain nuclei like globus pallidus, putamen, substantia nigra. These are all part of your extrapyramidal tract, and whenever extrapyramidal tract get damaged, you will have some movement disorders. A classical example, as someone commented, for extrapyramidal tract disease is Parkinson's, right? So you will have kind of similar features here. Once there is basal ganglia involvement, you start noticing that the patients start developing dystonia. They can have dysarthria as well. Dysarthria, slurring of speech, dystonia. They can have tremors, and they may have Parkinsonism. Now, can anybody name what is the classical tremor that we get in Wilson disease? The classical tremor, you can have various types of tremors, including the Parkinsonism type of tremor, but the classical tremor that we get in Wilson disease. I will show you a video. You should tell me whether you count that as a tremor or not first. So just take a close look at this video. First tell me whether this is tremor or not. And if you say this is tremor, I'll play it again. Then we will see what kind of tremor it is. It seems like he is playing a tabla, right? Okay, yes, it is a tremor. When do you call something as a tremor? When the movement is recurrent. The same movement keeps recurring again and again. If the same movement doesn't recur, but there are excessive abnormal movements, then it could be chorea, athetosis, balismus. In chorea, there are dance-like movements, but it is not the same movement that is recurring. But if patient keeps doing this, it's the same movement, wrist flexion, extension, right? This is what you call as, what is this tremor? It is called as flapping tremor that you get in hepatic encephalopathy. What you saw here is also a tremor because it is the same movement that is recurring. And one thing you notice is the movement is primarily occurring at the shoulder joint. So it is affecting proximal muscles, same movement recurring again and again. So it is a tremor involving proximal muscles. In Parkinson disease, you get this pill rolling tremor. It is a tremor involving distal muscles, right? Small muscles of the hand. Here, large muscles of the shoulder joint were affected. So yes, it was a tremor that we saw. And this classical tremor is called as wing beating tremor. It is called as wing beating tremor. Why am I calling it as wing beating tremor? You just witnessed a video where the person was doing this. It looks like the beating of the wings of a bird. That's why it is called as wing beating tremor. Now you have just seen a video, so I want you to comment and tell me whether this tremor is expected to be symmetric or asymmetric. What do you think? Is it expected to be symmetric or asymmetric? Let me take you through the video again. See it and tell me, what do you think it is? Symmetric or asymmetric? Yes, it is going to be asymmetric because when copper deposition starts happening in the basal ganglia, right? Both the sides of nuclei will not be simultaneously equally affected. One side there may be more copper deposition than the other side. So whichever side there is more copper deposition, it gets affected first and it will progress ahead of the other side. So anytime you see a patient, until and unless it is very advanced case, you will not have the wing beating tremor to be bilaterally symmetric. Same goes with the Parkinson disease also. In Parkinson disease, you will have this asymmetrical pill rolling tremors because one side substantia nigra is generally degenerated more than the other side. But if it is drug-induced Parkinsonism, it will be bilaterally symmetrical. So we are expecting it to be bilaterally asymmetrical, right? So this is usually going to be bilaterally asymmetrical tremor that we are getting. Okay, so these are the neurological manifestations that we are going to get. And as I've already told you, 40% patients at the time of presentation, they have hepatic manifestations. And 40% patients at the time of presentation, they have neurological manifestations. 20% get diagnosed without any symptoms because of screening or because of other symptoms, not hepatic and neurological. Okay, now this hepatic, when in the neurological, when there is deposition in the basal ganglia and we image, the T2 weighted MRI image is done, the midbrain appears like the face of a giant panda. As you see here, it appears like the face of a giant panda, right? It's a beautiful panda that you're seeing here. So we'll call it as face of giant panda sign. Face of giant panda sign. This is a potential image-based question for the NEET PG students. So just take a note of it. If you're writing your final prof exam, you just have to mention it. Of course, no need to sketch this image. Okay. Now, what other manifestations we can get? There can be involvement of the eye. So, one of the site where this copper gets deposited in the eye is the cornea. And when it comes to cornea, particularly they ask which layer. There will be corneal copper deposition. And corneal copper deposition primarily occurs in the Descemet's membrane. Descemet's membrane. And that deposition forms a ring, which we all know popularly. It is called as KF ring or Fisher ring. One of the MCQ that I had come across is, do you get this ring from the beginning itself, or it starts somewhere and then covers the entire circle of the cornea, right? Remember, it starts in the limbus and then expands to become a ring. So the initial place where it gets deposited is the limbus. Okay. Apart from that, there is also a deposition of copper in the lens. And copper deposition in the lens produces cataract. And what you call that cataract as? Yes, this is again an important opthal image-based question. We call it as sunflower cataract, because it will have a central disc and then it looks like, it appears that petals are emerging out of it. So it's called sunflower cataract. Now both of these are important image-based questions from the opthal side. Now what other manifestations we can expect? We can have the copper deposition in the kidneys, and kidneys cause damage mainly to the proximal convoluted tubule. Tubules get affected by copper deposition, and especially when PCT is affected, reabsorption of lot of substrates that are filtered, like the bicarbonate, the amino acids, all of them that get affected. So I start excreting high amount of bicarbonate, electrolytes and amino acids in the urine. Remember, we reabsorb majority of it in the PCT, but if PCT is damaged, we start excreting all of them in the urine. What do we call this syndrome as? It is called as Fanconi's syndrome. So renal manifestation of Wilson disease, it can present as Fanconi syndrome, where patients will have loss of glucose, electrolytes, bicarbonate and amino acids in urine, and amino acids in urine. Second, it can also affect the endocrine. It can cause hypoparathyroidism. The parathyroid gland activity gets affected by high copper, so it can cause hypoparathyroidism. Okay. Apart from that, the copper involvement. Okay, so what all organs we have covered? We started with the hepatic. Yes, we will start with chronic hepatitis, end up with cirrhosis. And I forgot to mention, cirrhosis is a risk factor for hepatocellular carcinoma. So Wilson disease can be considered as a risk factor for hepatocellular carcinoma, just like your hepatitis B, alcoholic liver disease, and non-alcoholic fatty liver disease. Neurological, basal ganglia is the most commonly affected, first affected site. Apart from that, cerebellum and other structures can also be affected. Patients can present with dystonia, dysarthria, tremors, Parkinsonism. Tremor is classically wing beating, which is usually bilaterally asymmetrical. Then eye, you can have copper deposition in the cornea as well as the lens. Lens causes sunflower cataract, corneal deposition causes KF ring. Renal, you can have the Fanconi syndrome and hypoparathyroidism. One more important thing that I had mentioned was we can have a hemolytic anemia. So we may end up with Coombs negative hemolytic anemia. Hemolytic anemia. In fact, this Coombs negative hemolytic anemia strongly correlates with the risk of the acute liver failure in a patient with Wilson disease. So if you have a patient with Wilson disease and then you end up with this Coombs negative hemolytic anemia, there's high chances that patient will have fulminant or acute liver failure as well, right? So that is another point. Now, once I get these patients, I have already told you that the opthal image-based questions are possible. So in the first image, you can see a brownish, golden brownish deposit here, this ring. This is what we are going to call it as the KF ring, Keshaw-Fisher ring or KF ring. In the second picture, you don't see, here you can see a full circle as a ring, right? Typical KF ring. But in the second picture, the lateral sides, you're not seeing the ring. You are only seeing in the limbus. So I have already told you the earliest site where copper deposition happens is the limbus, and as the time progresses, the circle becomes complete. So you don't see the circle from the beginning. As more and more copper deposition starts happening, the limbus starts expanding and completes the circle. In this image, you also notice that there is icterus. So there is KF ring at the limbus and there is also icterus. So this is KF ring plus this patient has, you can see that there is yellowish tinge. So there is icterus. That means this patient has liver involvement already, right? He is showing the signs of liver failure. Now in this image, you can notice that there is a KF ring, this brownish ring. But apart from that, if you look at the lens, you notice that there is some kind of cataract. There is a central disc and then petals emerging out. We are going to call it as sunflower cataract. sunflower cataract. So now if you encounter a patient with the Wilson disease, you should be able to recognize it with the help of the KF ring, as well as if there is neurological manifestations, you should be able to recognize them because of this classical tabla type wing beating tremor, right? Okay. Now, if I am suspecting that the patient may be having Wilson disease, how will I go for the diagnosis? If you are suspecting, we begin by looking at the serum ceruloplasmin. I have already told you that the serum ceruloplasmin will be low. The reason for low ceruloplasmin, the ceruloplasmin actually exists in apoceruloplasmin form, and if it is not bound by the copper, it gets destroyed. That's why the ceruloplasmin level goes down. And for binding with the copper, it needs ATP7B activity. If it is not there, it won't be bound by copper. Unbound gets destroyed, right? Simple. So we will have low serum ceruloplasmin level. Normal is 18 to 35 milligrams per deciliter. 18 to 35 milligrams per deciliter. And anything, just give me 1 second, guys. What happened? Okay, so let me write it down. The text disappeared. Serum ceruloplasmin level less than 20 milligrams per deciliter is the initial investigation. It is considered as serum ceruloplasmin is considered as the screening test of choice. So in any patient, if you're suspecting that he may be having Wilson disease, go ahead with serum ceruloplasmin. If it is low, then you can go ahead with the further investigation. So for further investigation, you can do 24-hour urinary copper estimation. 24-hour urinary free copper excretion. As I've already told you, in Wilson disease, the free copper starts leaking into the blood from the hepatocytes because it is not getting packed into the ceruloplasmin. So this free serum copper will get filtered or excreted by the urine. So you will have elevated 24-hour free urinary copper. More than 100 micrograms per day is specific, but you need not always have more than 100 micrograms per day. If it is more than 40 micrograms per day, it is already pointing towards Wilson disease. But if it is more than 100 microgram per day, it is relatively more specific. But if you ask me what is the gold standard investigation, that is liver copper quantification. So you can do a liver biopsy and then quantify how much copper is there per gram of liver. So if it is more than 250 micrograms of copper per gram of liver tissue, then it is highly suggestive of Wilson disease. And this hepatic copper estimation is considered as the gold standard investigation. Gold standard investigation. So if they ask you what is gold standard, liver biopsy, liver copper quantification. And if they ask you what is screening test, serum ceruloplasmin level. Now these are for the MCQs. But if you ask me, sir, how do you diagnose Wilson disease in real practice? In real practice, we follow something called as Leipzig score. It's called as Leipzig score. This may be a potential MCQ point, at least a name for the INI-CT. So in this score, the features of Parkinson disease are assigned different scores, and when the cumulative score in a patient is more than or equal to 4, it is suggestive of definitive Wilson disease. Definitive Wilson disease. So what are the components? First one is KF ring. So if there is KF ring, you give 2 points. Second one is ceruloplasmin. Ceruloplasmin less than 0.1 gram per liter, you give 2 points. If urinary copper excretion is more than 2 times the upper limit of normal, you give 2 points. If hepatic copper quantification, as I have already told you, more than 250 microgram per gram of liver tissue, you give 2 points. If neurological symptoms, what are the neurological symptoms? Dystonia, dysarthria, Parkinsonism, and the classical wing beating tremors. If any of these are there, you give 2 points. The last one, the genetic study done for the ATP7B mutation. If it is present, you give 4 points. And if a patient has 4 or more than 4 points, it is definitive Wilson disease. So now tell me, among these, which criteria alone is sufficient to make a diagnosis of Wilson disease? According to the Leipzig score or Leipzig criteria. Yes, if you have a symptomatic patient with Wilson disease and you get ATP7B mutation, you get 4 points and it is diagnostic. You don't need any other points to be met, right? Okay. So once with the Leipzig score, I have diagnosed. The next question is, how am I going to manage these patients? So let us talk about the management of Wilson disease. We know that it is causing the damage to the liver, brain, and other organs. So the drug of choice is going to be a copper chelating agent. You will give a copper chelating agent to bring down the organ load of copper. Amiguls are very good. Yes, if there is a mutation in a symptomatic patient, there is more than enough to diagnose the case as Wilson disease. You don't have to have a KF ring, you don't have to have the neurological manifestations. Good. Okay, so D-penicillamine is considered as the drug of choice. And this D-penicillamine is a copper chelating agent, just like how we had deferasirox or desferrioxime for the iron chelation. D-penicillamine is the copper chelating agent and it is the drug of choice. But it has some pitfalls. What are the pitfalls? Generally, when we start D-penicillamine, it worsens the neurological symptoms. So if patient's presentation is predominantly because of neurological symptoms, the situation worsens at least for few days to few weeks. So that's why in a patient presenting with predominant neurological symptoms, we should, instead of using D-penicillamine, we should think of alternatives. So this may worsen neurological symptoms initially. So all patients may not tolerate this D-penicillamine. So those who are not tolerating, in them what could be considered as the drug of choice or what could be considered as an alternative, right? So I would say alternative to D-penicillamine is trientine is another drug which is well tolerated by patients having the neurological symptoms, and that can be considered as the alternative, trientine. And then once I have done the chelation therapy and the organ load of the copper has come down, then should I continue to use the D-penicillamine? The answer is no. You can maintain with other drugs. Like for example, if I'm talking about hemochromatosis, when iron load on the tissues is very high, we go ahead with what we call as phlebotomy, right? We keep removing the blood till the organ load of iron comes down. And once it comes down, for maintenance, we were using chelating agent. So here we are using D-penicillamine till the organ burden of copper comes down. But after that, for maintenance, what can I use? Yes, we can use zinc acetate. Very good. So for the maintenance therapy, even trientine can be used. But if they are asking what is the drug of choice, zinc acetate is the drug of choice for the maintenance therapy. So the overall drug of choice is going to be D-penicillamine. Alternative to that is trientine. Let me also write it down in the MCQ perspective. So drug of choice for neurological Wilson disease is going to be trientine. This will be considered as the drug of choice. Alternatively, even zinc can be used for neurological, but avoid giving D-penicillamine, right? So that's about the Wilson disease. We will quickly recap the important MCQ points that may be asked in your NEET PG. So first question that they will ask is, what is the gene defect? The gene defect is ATP7B. 7A mutation causes Menkes disease. ATP7B, which is there on chromosome 13 mutation, causes Wilson disease. Inheritance wise, this is inherited as autosomal recessive condition, not autosomal dominant. First organ affected is going to be liver. First organ affected is liver. One of the MCQ I had noticed is KF ring may be absent in Wilson disease. When? If it is pure hepatic Wilson disease, means there is no neurological involvement, then KF ring is usually going to be absent. So KF ring kind of correlates with the neurological involvement. Okay. Diagnostic test of choice. What is the gold standard or the diagnostic test of choice? The hepatic copper quantification. More than 250 micrograms per gram of liver is suggestive of Wilson disease. But if they're asking what is the most specific investigation, most specific investigation is not. Remember, gold standard is hepatic copper quantification, but if the terminology changes, they ask what is most specific. Most specific is genetic studies. If there is ATP7B mutation in a symptomatic patient, it has to be Wilson's, right? So genetic testing for ATP7B mutation is the most specific investigation. For ATP7B mutation is the most specific investigation. Treatment of choice we just discussed, D-penicillamine is going to be the treatment of choice except patients with predominant neurological manifestation. And what is the alternative if there is intolerance? We can consider using trientine or zinc. Now, one last question. My patient doesn't want to take any of these treatment, but he doesn't want to have Wilson disease. Is that possible? Well, liver transplantation is curative. So, liver transplantation can be considered as curative for a patient with Wilson disease. So, you give a liver of someone else who has normally functioning ATP7B, the problem is solved. So, liver transplantation can be curative, right? And when should I suspect fulminant Wilson disease, or what we call as acute liver failure in today's terms? Any person who presents with, I've already told you this feature, that if someone presents with Coombs negative hemolytic anemia, it's highly suggestive of a coexisting acute liver failure. So if there is Coombs negative hemolytic anemia, along with that, if there is low ALP anemia, or the ALP by bilirubin ratio less than 4, these are potential clues to suspect the heralding of the acute liver failure in a patient with Wilson disease, right? So that kind of covers all the key MCQ points that we required. So that's it from me today. We will connect again in the next Reed Harrison series. I have not made a list of topics that I want to address. So let me know what topics you want me to address. According to that, we will continue with our further Reed Harrison series. That's it from me today. I'm signing off. I'll see you in the next class. Till then, have a good time. See you. Bye-bye.